Hello, welcome everybody. I am being joined by Dr. Smikle, who's the medical director of Laurel Fertility Care. It's been a couple of months since I've done a live with him, and I'm so looking forward to it because I do really love these lives. He's such a good person to speak to, and has so much wealth of experience and knowledge, which he's kindly going to share. Today it's about endometriosis, so a 101 about endometriosis, everything that you may not know or may want to know more about to do with endometriosis and living with it. We will demystify some of the myths, and also he'll answer your questions. So let me get him in now. Hello to those who are joining. Nice to see you. Hello, Dr. Schmeichel.
Hi, how are you doing?
Very well, thanks. How are you? I was just saying it's been probably a couple of months since we've spoken, and it's really nice to be doing an event with you again.
Well, it is great. It is great doing an event with you again. Thank you so much for actually having us join your group.
And of course, March is Endometriosis Awareness Month. And so obviously it feels very fitting to be asking you all about endometriosis. For those who are joining and may know something about it or not a lot about it, Laurel Fertility Care have written a brilliant article for us, demystifying facts and myths around it, and also sort of explaining about things that you may have to live with if you're living with endometriosis and the sort of options you've got available to support that. So can you just give us, for anyone joining, a brief summary about what endometriosis is?
So thanks for actually asking and introducing it. Endometriosis is an infiltrative disease that primarily occurs within the ovary or in the pelvis. There are different postulations or different thoughts in terms of how it arises. The first thought was it's the endometrial tissue that's supposed to be inside the uterus, basically flowing backwards through the fallopian tubes, either resting inside the ovaries themselves at the time of ovulation or implanting on the surfaces. So therefore, that's one thought. It could actually be from just abnormal growths that are similar to the tissue that's in the endometrium, but the effect is that it will grow, stimulate, and develop in areas that are outside the uterus. Typically, you would think about the uterus as being a place where your lining develops. If you don't have a period, or if you're not pregnant, or you're not trying to get pregnant, you'll shed that period, and then that bleeding will happen. That same thing happens within these implants. So therefore, if it's inside the ovary, then the blood will actually fill up in those chocolate cysts. It can actually travel into the lungs, into different areas, and so those same things happen, where with every cycle each month, you'll end up having bleeding into those areas. So it's a disease that can actually, it's primarily in the pelvis, but can actually be in other areas as well. But it does affect, someone's ability, if you will, to kind of basically function.
Mm-hmm.
Sometimes it causes a lot of pain. Sometimes it'll cause problems in terms of, either bladder or bowel movements. So therefore, there's a lot of symptoms that actually occur with endometriosis.
Mm-hmm. We just had a question actually. Can people conceive naturally with endometriosis?
Yes, you can. And, that's a very good question because, many times you may not even know you have endometriosis. You may end up having painful periods and then, some people will just basically ignore that pain and then they'll get pregnant naturally. Pregnancy is a good way to kind of manage the endometriosis because the pregnancy hormone will actually, for lack of a better term, proliferate and grow those implants. So therefore it'll burn out. So, there are some places where, there's some medications that were actually derived to make that pseudo-pregnancy state be part of that treatment.
Mm-hmm.
People might have heard using danazol, which is not something that's used anymore. But a lot of the things that are actually being able to suppress the endometriosis by sort of burning it out, if you will.
Yeah. Yeah. Zoe has just asked, what is it that may stop you being able to conceive? Why is it associated with fertility issues?
Well, typically, if endometriosis is going to be affecting the ovary, that's where it actually is going to play the most role. So, women with endometriosis, we know, especially if the endometriomas are involved in the ovary, may have fewer eggs.
Mm-hmm.
Because endometriosis is what we call an infiltrative disease, where it kind of grows with each menstrual cycle, that can actually then interfere and grow within the ovary itself. So women with endometriosis may end up having fewer eggs, end up having fewer opportunities. Comparing success rates with IVF, women will actually have fewer embryos to transfer. So it's not to say that there's a difference between the quality of the embryos. It just says you have fewer to start with. So women may end up having, not any at all. So therefore, they'll end up having fewer opportunities in the future in terms of getting pregnant.
Yeah.
So that's going to be the role. It can also play a role by causing scar tissue to form. So it may end up having scar tissue being in the fallopian tubes or in the ovary or in the intestines. So those scar tissues can actually then interfere with implantation or at least fertilization as well. So that's another way that endometriosis can interfere with getting pregnant.
So I've seen a lot of things in the fertility community around people struggling with endometriosis for years without it being diagnosed correctly. Why is it so hard to diagnose? And is that why people can end up having fertility issues? Because by the time it is diagnosed, they may have a lower egg count, for example.
That's actually a really good question and a really good going into that segue. People used to think that endometriosis didn't occur in teenagers, but because we don't quite know how it actually is formed, you'll end up having teenagers who have endometriosis. So those women are actually going to be ignored many times, and so therefore they'll end up going for longer periods of time before they're assessed, longer periods of time before they'll end up being getting any treatment, yeah. And they're going to end up having diminished responses to that part of it. So that's one way. The other measure is this, that it does require surgical intervention most times to diagnose endometriosis, either by laparoscopy or by basically having some evaluation. And so women who don't have surgery or don't have the means or access to surgery may end up not knowing what's going on. Women will get pregnant, and then therefore, they'll have to have one pregnancy and then end up having significant severe endometriosis that prevents them from having the second pregnancy. So therefore, there's a number of different facets that may actually cause it to interfere with the process itself.
Mm-hmm. Yeah. That makes sense. Thank you for that. I read somewhere that around 40% of people in the fertility community have endometriosis. And one of the things that you wrote in this amazing article, which I'll link up, about things that you may not have known about endometriosis, is that it's much more prevalent and common than you think. Do you see it a lot in patients?
Well, that is very, very true. A lot of times, let me kind of preface it by saying within the reproductive community, you'll end up seeing it more because you'll end up having more people coming to see us for evaluation for other causes of infertility. We're going to explore a lot more than, say a general gynecologist might, so therefore we're going to find out more of these symptoms. And then we're going to basically treat whatever we can. Someone may come in and they have an endometrioma within the ovary. And for us, for reproductive endocrinologists, one of the things that we know is just that we're trying to do as minimal amount of surgery as necessary, not because we can't manage the symptoms, it's just that our focus is making sure we preserve the eggs. And because we know it's an infiltrative disease, if you're going to do surgery and you're going to remove that endometrioma, you may also remove a lot of the eggs as well. So oftentimes you may end up having patients who go through IVF so we can get eggs with the endometrioma in place just to minimize the amount of loss there can actually be. So there's a number of facets to that part of the equation.
Mm-hmm. And it grows back, doesn't it? So is surgery something that someone will need to keep having throughout their life?
Unfortunately, until you go through menopause, you're going to end up having some possibility or at least the need for surgery. Or, there are people who, once they finish their reproductive lives, will end up going on birth control pills or going on some other measure to suppress the endometriosis from actually proliferating. But you're right, without really having some sort of suppression, you're going to end up having it recur.
And does endometriosis mean really heavy periods?
No, no. Not everyone with endometriosis will have heavy periods. And sometimes you'll end up having someone with lighter periods because you'll end up having a lot of that backflow into the pelvis. And therefore, you may say, well, you don't really have as many symptoms. You'll have primarily painful periods. But even with somebody with severe endometriosis, you can't always rely on pain being the only reason, the only way to find out if they have endometriosis. Because if somebody with really significant disease, who may even end up having obstruction of either the bladder or the bowel, can end up having no symptoms at all because basically they went through that phase where they had symptoms before, and now they're no longer having any further symptoms.
Mm-hmm. Yeah, that makes sense. And yeah, because one of the things that you've written about is that it's not just a bad period, it's so much more than that. And in terms of being specific for each person, why is the care individualized? How can it range so much from one person to another?
Well, each person's an individual, and they're going to be born with a certain number of eggs. Not everyone with endometriosis is going to end up having a reduction in their egg number, and not everyone's going to actually have the same extent of scarring from the endometriosis. So you are going to have to individualize their care. Different people have different, either their needs or their goals. So people who completed their parenting, and therefore they just need management of their symptoms, not for trying to get pregnant. So there's a whole host of reasons why you're going to have individualization of the care.
Mm-hmm. Yeah, that makes sense. And I think lots of people assume, don't they, that we said at the beginning that they won't be able to get pregnant if they get this diagnosis. What's your advice to people who get this diagnosis? Because I'm sure that it's really hard to suddenly hear that you've got that when there's so many negative things that people can read or find all over the internet that could scare them.
Well, I think the biggest thing to do is to basically be proactive and also basically be persistent. The reasons to say that is just that, again, really have very clear goals. And, if you're looking or you're asking questions, you're having these symptoms and you're not getting the answers that you feel comfortable with, find someone who's going to actually be able to explore differently and basically either do certain tests, ultrasounds, laparoscopy, if it's necessary, to evaluate and treat the endometriosis. The biggest reason is just that it's better to kind of do things and diagnose things earlier rather than later, because left alone or left for it to kind of basically run its course, the more you'll end up having more complications, more problems. Mm-hmm. So the better thing to do is to get diagnosed early and treat it early so you can kind of preserve the opportunity.
We've got a bit of feedback.
Yes, there's some construction going on next door. So
that's what we can hear. Sorry, everyone. I hope you can hear Dr. Smikle. If you've got questions for Dr. Smikle, please ask, because he's very happy to help. And someone just messaged privately just now, just saying that they just feel like it's not always taken that seriously by medical professionals. Do you think that sometimes it isn't evaluated when it should be, generally speaking, around the world?
I think there's a combination of two things, and then it's just that oftentimes, especially if someone's going to be complaining of a lot of symptoms, they're going to end up being ignored. And the more you, without really, if you're not going to be persistent, then you're not going to ask for, more definitive evaluations. Many of those patients are going to be pushed in terms of saying, well, you're just basically being, a baby, or you'll end up being stigmatized because of this pain. So there's a number of people, and there's the Endometriosis Society who has actually shown and said that what you need to do is to advocate and basically really be persistent. And the biggest reason for that is just that you want to make sure you're going to end up having someone who's going to take advantage and can follow and make sure you have that care understood. Because otherwise, you're going to be ignored. The big part is just that, there are places where you may not have access to laparoscopy or ultrasounds. So therefore, you're going to end up having physicians who may suspect endometriosis and then treat proactively rather than ignoring the symptoms that a patient may have. Sometimes you'll be put on birth control pills, which will mask the symptoms until you get further along. But any treatment's better than actually none at all.
Mm-hmm. And is the process of sort of flushing liquid through the tubes to see whether they're blocked, is that called hycosis?
That's one term for it. The other one is hysterosalpingogram. That's what the term that's used here. A saline sonogram is used to assess the uterus, and it'll also flow directly into the uterus, into the pelvis. One of the reasons why many of those tests are not done around the time of the, right around the time of the soon or during or soon after the menstrual cycle is because of the concern of flushing that tissue into the pelvis. It's not to say that that causes, but if you're someone who's predisposed towards having endometriosis, you may end up worsening some of those symptoms. The risk of infection and everything else is other things you can manage, but the concern is preserving opportunities, preserving someone's potential for the future. Mm-hmm. So that's going to be fashion.
And is it something that runs in the family? So if someone knows that their mother had it, it's worth exploring at an earlier stage because it could be something that they're experiencing.
It can, and it's something that it's not as correlated as, say, something like sickle cell or an inherited disorder. You may skip generations because it's still not clear as to what is the gene that causes it. We don't know that. So it basically it's a constellation of symptoms that basically you may end up having in the same family dynamic. So that may be where that exposure is. But it is something that you see in clusters in terms of within families.
Mm-hmm. And someone's just asked, do you have a different protocol for IVF if you have endometriosis?
You may need to, and the biggest reason for that is just that because those women may end up having fewer eggs, you'll need to stimulate more aggressively. You may end up needing to do more than one cycle to accomplish the same goals. Some patients are fortunate, and despite having endometriosis, they may have lots and lots of eggs. So it's going to come down to individualization of that patient, looking at their picture, getting a lot of the other information, whether they're AMH, their FSH, the follicle-stimulating hormone, and their antral count as measures to kind of see how you're going to individualize that care. But it does need to be individualized.
From everything you've said, which I've just learned about the lower AMH due to this, would you say that for younger patients or any patients who might be not ready necessarily to have a family but know that they've got this diagnosis or are looking into it, to freeze eggs?
Well, I think that's a really, really important thing to consider because we know it's an infiltrative disease. We know it's something that will worsen over time. So those individuals may actually consider freezing earlier than some women who basically are doing it just for their own well-being. Typically, when we're talking about fertility preservation, we're not often talking about it in women in their 20s. With someone who's endometriosis, that actually is going to be a significant difference. So you might encourage those individuals, even in their late teens, early 20s, to do that, just because of the concern of limiting how many eggs there will be available in the future.
So we've obviously talked about egg count, but what about egg quality? Does it have any effect on egg quality?
It doesn't seem to appear. It doesn't appear to have as much impact on egg quality as count. Still, you'll end up having fewer eggs, fewer embryos, and then you may end up having, because you're having fewer eggs, you may end up having fewer good quality eggs. But it doesn't. It's not enough to say that someone who is 30 with endometriosis is going to have a lower chance of success in terms of going through an IVF cycle than someone who's 30 without endometriosis. They'll end up having a slightly lower chance because they'll have fewer eggs. But if you compare an egg, embryo to embryo, they're both same quality embryos, both same quality in terms of how they're managed. Their chance of success is actually the same.
That's really good.
Or very similar. So that's one of the reasons to kind of be proactive at either freeze eggs, freeze embryos, just because you want to preserve that opportunity for the future.
Mm-hmm. Do you, is there much research happening at the moment into endometriosis? Because it seems like
there's a lot of information. There's a lot, sorry for kind of jumping, but there's a lot of information being evaluated for endometriosis. There are a lot of placental type markers that are actually being looked at as measures of precursors for either things that people are exploring to say that this is associated with endometriosis, or maybe something used to treat endometriosis. So therefore, there's a lot that's actually being done. There are a lot of new medications coming on board. Before, the medicine that was often used was developed as something that was a testosterone derivative, and it actually had some side effects in terms of, hair growth, deepening of the voice. That medication was called danazol. That's not even used anymore because we had so much different medications to do that, in addition to using birth control pills. They used to end up having Lupron for, injectable medicines for long periods of time. Now they're oral medicines you can use to treat. So therefore, there's a whole host of medicines now that's available for treating endometriosis, and not just surgery. And that's an important thing to kind of realize.
Yeah. Do these medications have side effects?
Well, the unfortunate thing is just that all these medicines, despite how they work, are going to be primarily trying to reduce the estrogen production, because we know estrogen stimulates endometriosis. So it reduces proliferation of endometriosis and tries to extend the reproductive life. The downside to that is just that you'll end up having some hypoestrogenic side effects. Women may end up having hot flashes. Women may end up having vaginal dryness. May end up having skin changes. So therefore, these are all things to kind of consider. I think people talk about using add-back therapy to reduce some of those symptoms. But primarily, it's something that you do have to work in concert with your physician to sort of manage the symptoms and the side effects.
Mm-hmm. Does endometriosis make sex painful?
It can make sex very, very painful. Endometriosis can actually infiltrate the vaginal canal and vaginal wall, so therefore it makes it so therefore just penetration is difficult. If it doesn't affect the vagina, it can actually be part of what we call the uterosacral ligaments, that the parts that are attached to the back of the uterus kind of support the uterus, and that can cause pain with deep penetration. So therefore, that's definitely one of the things and one of the hallmarks to ask about or to let someone know about when you're talking about when you're having symptoms of endometriosis.
Mm-hmm. Obviously, that's not ideal at all anyway, but let alone if you're trying to conceive.
Exactly. And I think sometimes what will end up happening is that, especially if, during ovulation, estrogen levels are going to be a bit higher, you're going to end up having pain at the time when you're ultimately going to want to try to conceive naturally. So therefore, that's one of the reasons why sometimes patients may not even have any other need or may actually consider going through something like intrauterine inseminations or other measures before moving on to something like IVF or other measures to try to get pregnant, just because of the aspect of pain.
That's a really, really good point. If anyone's got any questions for Dr. Smikle, please ask. Also head to our link in bio to read this fabulous article that Laurel Fertility Care have written for us, which includes kind of quotes from the community, shared stories about people struggling with endometriosis, as well as ways to get help and what to look for, and obviously how the team can support you. Is there anything else, Dr. Smikle, that you think we haven't covered that's worth mentioning whilst we're in Endometriosis Awareness Month?
Well, I think that the things that to summarize some of the points you made, getting diagnosed early. Age is not as much of a factor as basically managing symptoms, so therefore that's important to know. I know that there are mothers who are probably thinking that their teenagers may not have endometriosis, but having that explored earlier, if that's actually something that comes about, so therefore they can be diagnosed and managed earlier is an important thing as well. And looking at egg preservation, embryo preservation as a measure to manage success for the future. Those are the things to kind of basically focus on. The most important thing is to basically be your own best advocate, because without being, diagnosing and knowing what's going on, you may end up having to suffer the consequences of, not having the life you want, not having the family you want because of these symptoms.
Mm-hmm. That's such good advice. Thank you so much. And for giving up your time today, because I know you're busy in between surgeries. So we really, really appreciate your expertise. Thank you.
And I apologize for the background noise and everything else, but luckily we actually finished without any noise. But
Don't worry,
thank you
we
again
can
for
hear
having
you.
us.
We can hear you. No, that was brilliant. Thank you so much. And to those who have joined, any questions, please DM us or DM Laurel Fertility Care directly, and they'd be more than happy to help. So thank you very much.
You're welcome now. Take care.
Bye-bye.
All right.
Bye, everyone.
Bye-bye.